Bismillah ar-Rahman ar-Rahim. Now we will start the 9th session, peripheral vascular disease. And the first speaker, Dr. Sameh Mostafa. He will give a talk about Belloni occlusive disease, revascularization options and the preferences.
صباح الخير عليكم. بداية أحب أشكر أستاذ دكتور مسعد سليمان على الدعوة الكريمة، دكتور عبد العزيز حافظ واللجنة المنظمة، شكرا جزيلا. Chairpersons, my professors and colleagues, السلام عليكم. Today we are going to speak about the infragenicular disease, revascularization options and preferences in critical limb threatening ischemia. Critical limb ischemia either is caused by multi-level disease like this, or more commonly a diffuse tibial affection. It's common pattern in diabetic patient. The pattern of the tibial artery disease will determine how to do a revascularization. For example, when we have a localized disease like this, with a good tibial artery runoff and available vein conduit, we can do a popliteal posterior tibial bypass in the proximal leg like this, or in the distal third of the leg, or even to the anterior tibial artery. However, this is not the common issue. The commonest form is a diffuse tibial multi-level disease with a diffuse multi-segment affection. Here, angioplasty is created for this. This is an example of a single vessel run of peroneal artery, and after its dilatation and the food supply through the lumped-shaped collaterals of the ankle. Another example here of the peroneal artery single vessel run of angioplasty, and after that we dilated a small tiny collateral between the posterior tibial artery and the peroneal artery, supplying the foot through this tiny branch. Sometimes we cannot go from above, so we cannulate the arteries at the ankle, like the cannulation of the posterior tibial artery, anterior tibial artery, going through a tiny sheath or sheathless. After that, we snare or engage the wire through an angle catheter, fluffing of the lesion, and then we complete the mission from the femoral axis. So the options here are either antegrade angioplasty, retrograde angioplasty, either primarily or secondarily, and the appealing surgery when we have a relatively young, fit patient with a vein conduit and suitable tibial pattern, as we said before. Reviewing the literature, we have three big trials, the best CLI trials, which recommended bypass first strategy when the patient is eligible for both. The Basel trial in 2010, which recommend bypass first strategy when you have life expectancy more than 2 years. But this trial just discussed all infrainguinal revascularization and was not dedicated to the Belloni disease. However, the dedicated trial Basel II to the Belloni disease, published in 2023, it stated that the bypass first strategy had a 35% increased risk of major amputation and death when compared to angioplasty as a first option. However, in my opinion, this is a trend or the result of the initial work of the trial, because when we have a deep look at the final results of the trial, we had more death to all causes, more major adverse limb events, more adverse cardiovascular events, and more intervention in the angioplasty group. However, these numbers were found to be insignificant. And when we have a look at the amputation-free survival, they are a little bit similar, and the study stated that there is no difference between them. However, surprisingly enough, this is their p-value. The study stated also that because of the study didn't reach the planned target event numbers, uncertainty of the findings are to be considered. So more and more trials are needed to solve this issue. In Alexandria University, we conducted a study over 60 patients, 20 with antegrade PTA, 20 with retrograde PTA, and 20 patients with popliteal tibial bypass. This is a clinical presentation. These are the comorbidities, and coming to the outcome, we had limb complication in the surgery group, more redo angioplasty, more 1-year mortality, and more 1-year major amputation in the angioplasty group. However, all these numbers are proved to be insignificant. The only significant results in this study was about the 1-year primary patency, proving that surgery is more durable, and the increase in the ABI, proving surgery gives more foot perfusion. However, the 1-year limb salvage was found the same, with no significant differences between the three groups. The conclusion: surgery was found superior in patency. It gives more durable results, more foot perfusion, that the significant ABI increase in the surgery group was significantly higher than the increase in the PTA group. No reported redo, better overall survival, because we carefully choose the patient, young and fit, with a good health and a limited tibial disease. So it's logic to have a better overall survival. The free groin in the surgery group was due to the use of popliteal artery as an inflow instead of the common femoral artery. Angioplasty was found superior in, it is similar to surgery in amputation-free survival, no significant difference. It is redoable, you can do it multiple times. It's minimally invasive and no wound complications. However, retrograde PTA proved to have higher reintervention rate than the antegrade one in the tibial disease. The message is, we are surgeons, we love surgery, but it's not easy. You should have a certain condition to do your bypass. Young, fit patient for anesthesia, limited tibial artery disease, and a good vein conduit, and it's not the case in the majority of cases. So angioplasty will be a first choice in the majority of cases due to the nature and the pattern of the tibial artery disease, but prepare yourself for redo. Retrograde PTA, we use it and recommend it as a secondary maneuver when you fail to pass from above, but not as a first choice, because it has a higher reintervention rate. So prepare yourself again when you use it to higher reocclusion rate and higher reintervention. When you have young fit patient, surgery will be the first choice because it is durable. Do we really need this durability? In fact, yes, because ischemic diabetic foot lesions are repeated events in the patient, prolonged life expectancy in these days. The degree of foot damage, the more damage the foot, the more you want perfusion. So surgery offers you a better perfusion. It's free groin in all, and we should have adequate foot arch. Finally, more and more studies are needed to solve this issue. Thank you very much.